Chapter 19, Cardiac Physiology, Screencast 3. Now, this will be a relatively short screencast, but it's actually focusing on the ECG. And remember, this is what was covered in lab prior to our ECG activity. Now, when we use the term electrocardiogram, you will interchange or hear interchange ECG, EKG. It does not matter which abbreviation you're using. The EKG is traditionally coming from where a lot of the initial work that was done in electrocardiography was done by German scientists, hence the K as opposed to the C. Now, what an EKG is, you're looking at skin electrodes that are detecting the electrical signals that are being generated by cardiac muscle. Now, what the EKG machine actually does, it sums all the electrical activity being produced by the contractile cells, and it generates what we see here as a general pattern of an ECG. Now, when we look at an ECG, we are primarily going to be responsible for, in this course, for the wave configurations. I'll talk a little bit about segments and intervals, but they're not really anything that I will ask on a unit exam. But you are responsible for knowing the actual wave configurations of the ECG and the electrical, not mechanical events associated with the EKG. If we look at the EKG, we'll notice we have a P wave, a QRS complex, and a T wave. And each one of these waveforms is associated with an electrical event. The P wave is associated with atrial depolarization. The QRS complex is ventricular repolarization. And the T wave is ventricular repolarization. Please note what we really are looking at is a moving graph. The x-axis is time, and the y-axis is actually electrical activity measured in millivolts. And here we can see that there is significant difference happening or amount of electrical activity being measured when the atria depolarize versus ventricular depolarization. I hope this makes sense because we know that the ventricles are much more muscular than the atria, so they're going to be generating significantly more electrical activity. So once again, the P wave is atrial depolarization. The QRS complex is ventricular depolarization, and the T wave is ventricular repolarization. It does appear that something is missing, though. We do not see a waveform that is responsible or indicative of atrial repolarization. Now, there is another P wave being generated, so they have to repolarize, otherwise they could not depolarize again. Now, the term we use here is that atrial repolarization is buried by the QRS complex. So the QRS complex, or ventricular depolarization, is a very significant electrical event. And when we look at atrial repolarization, it is not as big. So it's buried. We see ventricular depolarization, but at the same time, atrial repolarization is occurring. We just don't see it. Now, one thing that I really want to reinforce is the fact that when we're looking at the ECG, it is an electrical record. It is not a record of mechanical activity. This is really important, okay? We are not getting any mechanical record. It is strictly an electrical record, but there are some things that we can infer. Now, remember, if we're looking at flatline, these intervals here, okay, 0 millivolts, that's indicating there's no electrical activity. What's happening during that time, if we look at the PQ segment, that is going to be associated with the contraction of the atria. If we look at the ST segment, that is associated with ventricular contraction. Now, keep in mind, okay, the ECG is still an electrical record. We are just inferring that because there's no electrical activity, something mechanical is happening during that time frame. Now, when we look at the PR interval, that is the time from the beginning of the P wave to the beginning of the QRS complex, from atrial depolarization to the beginning of ventricular depolarization. This is the amount of time that it takes to move through the entire conduction system. When we look at the QT interval, we're now really looking about the time reflective of ventricular action potentials. Now here, we're basically looking at differences between the electrical activity that is generated by the contraction of an atrial cell versus a ventricular cell. And we can see once again, these are action potentials that are comparable to what we saw previously of a contractile cell in the previous screencast. But once again, look at the difference in electrical activity. Because the ventricles are much more muscular, they're generating a lot more electrical activity, and that is going to account for the difference in size that we see here. Now, this is a figure that really is just talking about or indicating the electrical events happening between the atria versus the ventricles and indicating what parts of the ECG are responsible for those atrial and ventricular events. Now, the next few slides are focusing on arrhythmias. And once again, this is much more of an informational topic and not something that I will probably focus on a unit exam. But since many of you going into clinical programs, I think it is important to have an understanding of what these are. So when we look at heart blocks, they are a conduction issue. So for some reason, there is an issue in how electrical activity is being sent between the atria and the ventricles. Now, some symptoms that are quite often associated with these conduction blocks are lightheadedness, fainting, irregular heartbeat, and chest palpitations. And once again, the severity of the conduction deficit, the more significant the symptoms. The first degree AV block is strictly an elongation of the PR interval. What this means is there's a slower than normal conduction of the electrical activity between the atria and the ventricles. Now, keep in mind, when we're talking about normal sinus rhythm, we are going to see a P wave for every QRS complex. That's important. So we're going to indicate that as normal sinus rhythm. And remember, mind your P's and Q's. So once again, normal sinus rhythm is going to be indicated by P waves always preceding QRS complexes. Now, when we look at second degree AV block, now not all of the atrial action potentials are going to reach the ventricles. So this means we are going to see some QR complexes not associated with the P wave. So then we have third degree block. And third degree block is especially significant. What this means is there are no atrial action potentials making their way to the ventricles. So there is a complete disconnect between atrial action and ventricular action. So they will be basically doing their own thing. There will be a rate of atrial action potentials and a rate of ventricular, but they're not related and completely random, but they are independent of each other and following their own rhythm. This next arrhythmia is atrial fibrillation. Generally, we have an emphasis to put the emphasis on ventricular arrhythmias. Now, atrial fibrillation can be an issue. And one of the things here is it's quite often described as a sawtooth look as far as the atrial waves. And so here, we're really looking at this chaotic timing of atrial action potentials. One of the issues that's associated with atrial fibrillation is increased risk for stroke. And once again, this is due to the fact that the blood is not moving and it has the potential to clot, and that clotting resulting in a stroke. So something that we see quite often associated with atrial fibrillation. The next here is what we refer to as a premature ventricular contraction. The top image is a 12 lead. So this is a standard ECG record, and it has a total of 12 electrical views of the heart coming from a total of 10 electrodes, 6 chest leads and 4 limb leads, together providing 12 electrical views of the heart. And each one of these electrical views, you will see that there is a beat that looks very different or not like the others. And you'll also notice that is not preceded by a P wave. Now here is an isolated PVC or premature ventricular contraction. And really what's happening here is there's just basically an extra beat. Now, that could be due to stress, stimulants, deprivation of sleep. I get them fairly regularly, and it's tied into my caffeine consumption. Now, the individual premature ventricular contraction is a non-issue. The problem, though, is when they become increasing in frequency. As they become more frequent, we're really looking at a loss of the electrical stability of the myocardium. And if this continues, it could result in ventricular fibrillation, and ventricular fibrillation is a lethal arrhythmia. If we were to actually try to calculate the heart rate that's exhibited here during VFib, you're probably looking at something greater than 300. There's no way that you're going to be able to really generate any meaningful cardiac output with a rate that high. So one thing that I was indicated as far as what does ventricular fibrillation look like, take a ball of Jell-O and just wiggle it really fast. And that's probably a good simulation of what a fibrillating heart is going to look like. Okay? Now, this is going to be treated by a defibrillator. Now, let's take a step back here. When we look at the conduction system, I like referring to it as the operating system of the heart. And when someone is being defibrillated, what's actually happening, that large shock is actually clearing out all of the electrical activity. And the hope is that you're going to see a stabilization of the operating system and you'll get back to normal sinus rhythm.